Hello, welcome to another in our series of short topics. Today we're going to talk a little bit about surgical pathology of the oral cavity, primarily some of the benign lesions and the related inflammatory and some of the pigmented lesions. So this is part one of a larger series on the oral cavity that we intend to add to those we've done in GI and GYN pathology, which also have areas of squamous mucosal tissue. I'll just emphasize that I don't have any secondary gains to be had from this presentation today, and this is one of my better looking photos from a few years ago. So, all right, so let's just think about some of the inflammatory lesions that arise in the mouth, lips, and surrounding areas. These involve the minor salivary glands, where we can get mucocell or salivary duct cysts. Sometimes we make stones in this area, and occasionally this lesion, necrotizing sialometaplasia, becomes a challenging area. Cheilitis, autoimmune sialadenitis can certainly masquerade as a tumor. And then some of the other types of lesions that can occur here are much less frequent in my experience, and probably will be in yours as well. So mucocells, of course, very common, typically on the lower lip or lower tongue, occasionally on the floor of the mouth, buccal mucosa from time to time. Typically, these are younger patients. They may wax and wane. And eventually most of these will tend to resolve. But because not all of them do, or they may do so slowly, they sometimes show up as biopsy samples, concerns for possible neoplasia. And sometimes we have very little in the way of remaining epithelium due to the extravasation and the inflammatory response, which we'll illustrate with some slides here. So grossly, here's what they kind of look like. Not hard to pick out. Very sort of clear, raised, fairly sharp bordered type lesions, sometimes with sort of a more of a bulge, depending on how deep they may be. Here's a ranula type of minor lower mandibular salivary gland and so forth, or lingual salivary gland and so forth. But most of them are related to minor salivary glands or other ductal structures in the mouth. So here's a nice example. Here you can see the squamous mucosa on this lesion, and we have minor salivary gland here with obviously a cystic space here with a bit of inflammation around the wall and an intact double layer of epithelial cells, very bland appearing. Lumen contents, sort of watery mucinous fluid. Another example here in the next slide. Here again, you see the squamous mucosa, minor salivary gland. And here the cyst is still intact. It's a little bit more eosinophilic because in this case, there's a bit more inflammation associated with it. And here we see that we have actually lost most of the epithelium as we go around the periphery of this cyst wall. We see just a fibrous wall with a few inflammatory histiocytic cells here in the lumen. And so as this sits here long enough, either due to irritation factors or the luminal digestive contents, maybe ischemic changes and otherwise, you can actually lose the epithelium entirely from these lesions. Go to another slide here. So here's kind of what we're looking for. With a salivary duct cyst, we usually do not have the associated minor salivary gland. We'll just see something, maybe a small duct heading down. And that will be what we might see. So if we don't see the minor salivary gland and we just see a nice duct here, we'll make the diagnosis of salivary duct cyst. These are essentially identical to the mucocells because those are usually associated with minor salivary glands. Well, let's go on to another lesion that occasionally comes across the desk with a biopsy and so forth. Sort of a little bit further out, but a very similar appearance. You see these sort of watery vesicles, but here there's multiple of these. There's not a single lesion, and it's usually here on the lower lip. Occasionally you might see it on the upper lip in a mature adult, maybe with some actinic damage. And this is again, an inflammatory lesion that may lead to partial duct obstruction and dilatation, leading to that sort of watery surface appearance. And here you can see variable columnar and squamous mucosa with an associated inflammatory process and glandular dilatation on an actinically damaged surface. Well, of course, the more classic scenario is true actinic cheilitis, which again, usually a lower lip process, someone who's a mature adult, and it can look very red, as you see here, with associated areas of squamous atypia. Here is the biopsy from this lesion, and we see the elastotic actinic damage, some inflammation, and here I'll pull it around so we can get it oriented a little bit more naturally for us. And notice that we have parakeratosis, just as we would in the skin, and on higher magnification, we see that there's a degree of basilar atypia and jumbling associated with this scenario that would be consistent with actinic cheilitis. It's not overwhelming atypia, but it's definitely present. There's an enlargement of some of the cells, maybe a bizarre mitotic figure or something, and of course the parakeratosis. Well, pigmented lesions also can occur within the mouth. These can be both melanocytic as well as non-melanocytic, and we'll take just a second and consider the non-melanocytic ones first. Three main types: an amalgam tattoo, graphite tattoo may be also induced, or some medication-related tattoos can also occur. And actually, that's the first one we'll look at. So here is an example of that. And as we look at this here, we see that there is a bit of granular gray-black pigment here. This is in the skin, but a similar appearance would be found in the oral mucosa, often around vessels, as we see here. And this is secondary to minocycline. Sometimes it has a little bit more orange color than gray-black, as we see here, but the location is quite characteristic because this is a systemic exposure rather than a topical exposure. Amalgam tattoos, although many dental procedures are done using non-mercury based products now in many older patients or some environments, that process can lead to the deposition of pigment here in kind of an interstitial pattern, some perivascular, but also interstitial. And it's a very black and sometimes a little bit chunky in its appearance, as you see here, due to the dental amalgam. Usually this is located on the buccal mucosa or occasionally on the gingiva, and of course would be associated with those type of procedures in history. Here's an example of an amalgam tattoo seen adjacent to the deep dental cavity there. So just to sort of summarize, minocycline, perivascular, granular, a little bit more brown. Graphite tattoos, similar to what you see in the skin. And amalgam tends to be a little bit chunky, sometimes has a foreign body reaction, as you see here in the scenario as well. Well, going on to the melanophytic-related lesions, one of these is the mucosal melanotic macule, very frequently seen here in the lower lip or lower lip macule here, as you see here in the upper right. But they can occur in a variety of other locations, from the gingiva to the buccal mucosa as well. These typically have a very lentiginous type of appearance, with just basal hyperpigmentation and no melanocytic proliferation, as you might anticipate in a more nevoid type of lesion. So because they're non-nevoid, they don't elevate the mucosa, it's still very smooth. Now, melanocytic nevi are, again, usually acquired, but can occur on the oral mucosa. Here you see one slightly raised. These can be of either the mucosal type, but other types, blue nevi, compound nevi, also can occur, and sometimes even combined nevi. So being aware that it's a pigmented lesion and a concern for melanoma may be the question. Being able to classify it as to the type of nevus can be helpful. Now, dysplasia can develop in these nevi as well, and melanoma, at least in the oral cavity, appears to arise from these dysplastic nevi precursors. These are usually a centimeter or so before the development of frank melanoma. But as you can see, excision can be quite problematic. A lesion like this, very difficult to get any kind of margin around. And so just close clinical follow-up with early excision of anything that looks particularly atypical may be the most appropriate type of follow-up. And dysplasia in these nevi can be variable from very mild to more severe. And it follows the patterns that we see in other sites with suprabasilar spread, nuclear atypia, occasionally some bridging and pigment incontinence, as well as some of the other features of dysplasia in terms of asymmetry and irregularity of the margins. Now, oral melanoma is also possible. Of course, in this situation, the staging is not quite as standardized as in cutaneous melanoma, but Breslow depth and a rough estimation of Clark's level are still performed, although these are not as highly predictive of behavior as in cutaneous melanoma. Metastases to the nodes are quite prominent, ranging up from 25 to almost 50%. And again, in this situation, using molecular markers to guide therapy may be appropriate. Interestingly, amelanotic lesions can also occur in the mouth. And in that circumstance, you're looking at a slightly different differential diagnosis, such as lymphomas or plasmacytomas, maybe even undifferentiated carcinoma with a very high-grade appearance. But keeping in your mind the possibility of melanoma when dealing with a mucosal biopsy from the mouth is worth doing. So we've got just one nice slide example to look at here in this situation. And to orient ourselves here, we have a surface here that I believe is somewhat ulcerated and vascularized. It actually appears as though this has moved into the bone of the mandible. Here we see the nerve here and tumor infiltrating within and in between the bony trabeculae. Now, interestingly, we have this pseudoangiomatous pattern, which can be seen in melanoma, as well as many other tumors. But this sort of angiocentricity is certainly one feature that should raise consideration for melanoma. And finding pigment associated with the tumor, as we do here, would help to confirm the diagnosis. But as we've mentioned, amelanotic melanomas certainly do occur. The morphology of a diffuse malignant tumor, fairly high grade without much glandular formation, so maybe the pseudoangiomatous proliferation, mitotic activity, Nucleoli can be present and so forth, but not always. We don't see any of the nice cherry red nucleoli that oftentimes are associated with oral melanomas and melanomas in other sites. So a nice example there. So that sort of brings us to the conclusion of our cases on this part 1 topic. We'll bring in some topics from part 2 and introduce those in a future session. I appreciate you taking the time to be with me today and hope this will be useful to you as we continue to explore some of the interesting findings that can come as we evaluate lesions in the earliest part of the digestive system in the oral cavity. So until next time, thanks very much for joining me.